Good evening. Welcome back to my IVF and the European Fertility Society. We are back with Dr. Vladimir Silva. You can see him right here. Hello, Dr. Silva. Great to have you back. It's been not so long ago, actually, that we had.
Yeah.
So I'm glad that we are going to discuss this particular topic. And how are you feeling today? Are you ready to share your knowledge and, of course,
Uh,
with all of us
okay.
today?
Well, hi, Caroline. Once again, it's always a pleasure to be here with my IVF Answers and the European Fertility Society. As you know, it's a pleasure for me to be here. I always love to do these webinars. Today we have a very interesting topic, one of my favorites actually, and so I wouldn't call it share my knowledge. I would call it share all other people's knowledge and discuss it. So
Of
I'm very
course.
happy to discuss it with you.
Brilliant. Thank you so much for joining. Once again, it's always great to have you. And remember that we will discuss it. First of all, we will talk about PGTA, and Dr. Silva will actually have he has a presentation on this topic, but afterwards there will be time for your questions. So all you need to do, type those in the chat so Dr. Silva can answer them for you. And Dr. Silva will share his screen so you can see his presentation. We can do it now, I think, and we can go ahead with our presentation. Remember, all is recorded, and you will have a chance to rewatch this as it will be available on our website tomorrow. And yeah, let's share the screen and let's make sure that we can all see it. I believe that everyone can hear us loud and clear, but just in case, confirm it for us. But I think everything is working. So
Okay, fine. You can also already see my screen, right?
yes, we can. So let's
Okay, here we
do it
are.
in a full screen here, and
Yeah,
now we can
okay.
go ahead with
Uh,
our presentation. Let's go.
Uh, okay, so good evening, everyone. Tonight we are here to talk about PGTA, pre-implantation genetic testing for aneuploidies. That's what this means. The title for this presentation was given by the European Fertility Society. It's called PGTA Success Stories Explained, Outcome versus Total Cost of the IVF Treatment. Okay, I will not focus so much on the cost. I mean, we can obviously discuss it on the Q&A, but my goal is more or less to explain you how can this help you making decisions, programming, scheduling your treatment, and making options. Because PGTA you will see is more about giving you information to make informed decisions about your reproductive future. My name is Vladimir Silva. I'm the CEO of two Portuguese clinics, Ferticentro and Procriar. Ferticentro in Coimbra, Procriar in Porto. So starting from the beginning, when we talk about IVF and genetics, so humans, mankind we cannot interfere with genetics. Okay, we can tell whether an embryo is viable or not, but we cannot change the genetic content of an embryo. So what can we do on this topic? So we can talk a lot. Okay, we can do webinars. We can spend a lot of time talking to patients. We need to counsel our patients very well. That's the main point on IVF, on PGTA, and when we talk about genetics, because unfortunately, genetics is something that essentially about information. We can tell what's happening, but we cannot change what's happening. We can do obviously all that we can to create great embryos. We can use the best technologies, the best culture media, the best medication, and so on. We can maximize the odds on that front, try to get as many embryos as possible and make sure that these embryos are as good as possible. Then we can test those embryos to see if what's their genetic content, and then what we can do is counsel the patients. We cannot change the genetic content of the embryos, and so this is the reason why we do PGTA. So again, sometimes a lot of patients ask us, well, but what's the point of all of this? Why don't we just let nature do its role? Well, actually, there is some degree of so that sentence is not completely wrong, but we have to understand that when we talk about IVF and genetics, we use IVF to prevent the transmission of genetic diseases. Uh, this is a kind of a summary of the situations where genetics play an important role in IVF. Okay, so we can use genetics and IVF to prevent the transmission of genetic diseases. If someone is a carrier of a genetic disease that can be passed to the offspring, we can use genetics to minimize that risk. We can use genetics to screen for potential genetic problems, age-related ones. This is where PGTA stands. Okay, that's what this presentation will be about. And obviously, we can also find HLA-compatible embryos in very special cases, which is not the aim of this presentation. So then we have these type of tests. I'm mentioning them just to make the distinction. Okay, there are the pre-implantation genetic test for monogenic diseases, which is called PGTM. This is, for example, for diseases like diseases that only affect a single gene, uh, Huntington disease. I mean, lots of diseases that they can be recessive or dominant. In a dominant disease, if someone is affected, they have a 50% chance of transmitting the disease to a child. If it's a recessive disease, the risk only exists if both elements of the couple are simultaneously carriers of the same mutations, and in those cases, there is a 25% chance of transmitting the disease. This is not what we're talking about today. Okay, I'm just mentioning it here to establish the difference. Then there's the topic of our presentation when we test embryos for aneuploidies. Aneuploidies are numerical chromosomal abnormalities. It's what we call PGTA. Then there is pre-implantation genetic testing for structural rearrangements, PGT-SR. What is that? Sometimes some people have uh, chromosomes, they just change parts. So a part of the chromosome is in the other and vice versa. And so in total, people have a balanced amount of DNA. So they don't have any condition. They have a normal phenotype and not any health problem, any related health problem. But when they are forming their gametes, meaning their eggs and their sperm, there could be problems because there could be an imbalanced transmission to the children. It's very close to PGTA, but it is also not the topic for tonight. And then we have the test for HLA compatibility. It's one of those cases where a child is affected by a genetic by a very serious disease, and then we need to get a baby. To have patients need to have another baby that can donate cells to treat the condition of the already born child. It's a very rare; those are very rare situations, but medicine is able to use genetic testings to help treat on that. That's also not what we're talking about tonight. So talking about PGTA, in the past, this was designated by pre-implantation genetic screening. The name was changed into PGTA because it's more correct, because we are talking about actually screening for aneuploidies. It is a genetic test that is performed on embryos to screen for numerical chromosomal abnormalities. So when we say that an embryo is aneuploid, this means that this embryo has an extra or a missing chromosome. This is because we know that embryos that have extra or missing chromosomes, they often fail to implant, and so it could lead to a miscarriage, or so they often fail to implant, and then the pregnancy test is negative, or they can also lead to miscarriages. So we have a positive pregnancy test, but typically in the first trimester, around 6, 7, 8, 9 weeks, we have a miscarriage. And but obviously, some of these abnormalities are compatible with life, and so this could lead to the birth of a child with a genetic condition or a seriously handicapped child. Okay, embryos that are found to be chromosomally normal are referred to as euploid, and they are most likely to lead to a successful pregnancy. Okay, this is why, so we can identify those good prognosis embryos, and that will save time to pregnancy. That will, going back to the title of this presentation, that will save the patient some money in frozen embryo transfers if we only transfer the euploid embryos. At our clinics, we do PGTA with next generation sequencing, which allows us to analyze all 24 chromosomes. This is now routine, I believe, everywhere in the world. And there are new techniques for PGTA, which are even more accurate, more precise, where we can get even more reliable information. So science is evolving, and the quality of the genetic testing available, it's becoming more and more. It's coming higher and higher, and so this has become a very reliable method. So when we do a PGTA, we detect the chromosomal abnormalities prior to the embryo transfer, and so this allows patients to make informed decisions on their treatments. Like I said in the beginning, doing PGTA doesn't make the embryos better. It gives us information and the capacity to select the best embryo. By transferring the best embryos, we reduce the number of cycles needed to obtain a pregnancy, and this is how PGTA actually saves money. Obviously, this needs to be assessed in on an individual basis. If you just have one embryo, it's more about the information than the cost saving, because in those cases it will actually add some cost. But if you have 10 embryos, doing PGTA will certainly save you a lot of money, because it's very unlikely that those 10 blastocysts are all viable. This is a graphic from iGenomics, one of the most important international genetics labs, where they've identified the probability of having a euploid embryo, or in this case, the opposite, an aneuploid embryo. Okay, so we know that when we are dealing with younger patients below the age of 35, only 36 to 40% of the embryos carry genetic abnormalities. That's what we could call the typical probability in the human species. And then, as long with the rise of maternal age, you can see that more and more embryos are carriers of genetic abnormalities that are not compatible with life. And so, for example, when we are here around between 38 and 40, we will have a 64% chance that an embryo is abnormal. Okay, this is where we draw the line. Okay, in Portugal, and I'm obviously talking about Portugal, we can do PGTA without any restriction above the age of 39, including 39. Below the age of 39, we only do PGTA in cases where there is a formal indication to do it. For example, a patient that has transferred 3 embryos without success, a patient that has had a previous pregnancy with an abnormal embryo or fetus, a patient that has had at least 2 miscarriages. Those are situations where PGTA is formally indicated, as well as a maternal age equal or higher than 39. Okay, and the explanation is here. That's when it really becomes a very high risk situation. This is why at our clinics we always recommend PGTA above the age of 39. Okay, regarding this, there's this very interesting graphic from Genomics. I usually like to show these graphics in my presentations. This is available in their website, but it is very interesting because you can, if you look into the left-hand graphic, you will see that on the gray bar, the grayish bars, you will have the results, the probability of implantation for embryos with PGTA across different age groups. And you can see that these probabilities are relatively stable and quite high actually, for so they don't change so much with age. However, if you look at all cases, IVF without PGTA, so an unselected sample, you can see that the probability of implantation goes down and down. This has to, it's obviously, like I said in the beginning, PGTA is not improving the quality of these embryos. It is just allowing us to transfer just the best embryo for these patients. Okay, and so this is the living explanation of the title of this presentation. What we know is that if we transfer good prognosis embryos, the time to pregnancy will be shorter. Okay, and that's very important because nobody likes, not the clinics, not the patients, nobody wants to have negative results. Okay, and so it's preferable to understand the genetic quality of an embryo and before transferring that embryo. That will give the patient the necessary information. It could be a if, good to know, or it could be bad news. Okay, no, for example, if we don't have viable embryos. However, it is the truth. Okay, and we can't do anything about it. That's so in genetics. When dealing with genetics, we feel sometimes a little bit powerless because there's really nothing we can do to change genetics. However, we can change our attitude in front of the genetic information, and that's what PGTA is for, in my opinion. We have the same information on the central graphic, but looking into deliveries, it's the same, more or less a very stable and high percentage across different age groups when we do PGTA, and obviously it goes down when we have an unselected group of patients, and the opposite happens with miscarriages rates. So since the embryos are tested, the miscarriages that happen in the gray bars are probably not related with the embryo. There are other causes for miscarriage, uterine causes, obstetric causes, but when here in a sample that's not affected, in a sample, in a group of patients that's not selected, you can see that the probability of a miscarriage can be very high, especially at higher ages. Okay, so I just introduced here also some information on PGTSR, because in a lot of countries and especially some patients, when they contact us asking for PGTA, what they are really looking for is PGTSR. So what is this? Like I said before, PGTSR stands for pre-implantation genetic testing for structural chromosomal rearrangements. It is a test that we use to screen for chromosomal structural rearrangements, normally caused by balanced translocations and inversions. Okay, it is intended by patients who are known to carry this karyotype abnormalities. This can occur spontaneously. So these are what we call de novo rearrangements, or this can also be inherited. Their incidence is in 1 in every 500 persons. A lot of, like I said, this is when a chromosome swaps apart. There is a part of a chromosome that is placed in another chromosome, and vice versa, and so people all have all the DNA they need. Okay, and so there are no consequences in terms of the health of how the person looks and so on. So this means that when we find these cases by asking the patients to do a karyotype, as I was saying, a lot of patients contact us to do PGTSR, but they call it PGTA. This is why I've included this slide in the presentation. So the carriers of these balanced rearrangements can pass down the same rearrangement, or they can produce embryos with unbalanced chromosome rearrangements. Usually, most of these cases are implantation failure, or we can also have miscarriages associated with these situations. Ultimately, this can lead to the birth of a child with genetic abnormalities. And so this is not about screening, this is more about treating, is more about identifying the viable embryos that are connected to these changes of genetic material between chromosomes. What we can, and so these are duplications, deletions, inversions, translocations, and so we use the test from a technical standpoint is slightly different because we use higher resolution probes to identify the most likely affected chromosomes. Okay, so it is important that these cases are treated differently from a technical standpoint. And so, since this webinar is about telling stories of patients, I'm going to tell a few stories so you can see what is the reality for us, the IVF clinics, when we deal with this kind of situations. For example, this patient, we call it, these are obviously fake names, okay? We call her Joanna. She was 42 years old when she came to us. She was single. She never tried to get pregnant. She had a normal BMI. She had an incredible AMH, 5.1, which is absolutely not normal for this age. FSH 6.5, LH 6.3. We did a stimulation well, it is in French, with 300 international units of HMG a day. We ended up having 9 eggs, 2 day 6 blastocysts. Sometimes patients are very uncomfortable when we have day 6 blastocysts, but this really can mean nothing. It really depends on the embryo. And then we did the PGTA, and we had actually 2 transferable embryos. One was called euploid. One was considered to be, so we had 2 embryos. One in euploid, we did PGTA to 2 embryos, one in euploid, one mosaic. It was a 30% mosaic. What does it mean? It means that in that embryo there are 2 cell lines: a normal cell line with a normal euploid constitution, and an abnormal cell line that occupied 30% of the embryos. Okay, this type of mosaicism is considered to be normal and compatible with life. The most recent research that was published considers that we should transfer these embryos, and actually most genetic labs are not reporting mosaicism anymore because this was found to be essentially irrelevant. Okay, back in these days when we did this case, we were evaluating different degrees of mosaicism. Now they even have artificial intelligence techniques to help them identify which are the embryos where they should care about mosaicism or not. So we transferred this embryo, the mosaic one, and we had a healthy child with a normal karyotype. Okay, we did amniocentesis during the pregnancy to make sure that everything was fine, and it was fine, luckily. So this is a case of a patient where she had even though she had no history of infertility, she had the age factor. She didn't have a lot of eggs, but she still had 9 eggs, and then only 1 viable embryo at the end of the day. It was, if we hadn't done PGTA, we would have done 2 embryo transfers. We would have got a pregnancy out of 2. By doing this, we only did 1 embryo transfer, and we got the pregnancy. Okay, so, and it was also very important for this patient to do PGTA because when patients are 42, we always start talking about egg donation. Okay, and then it's a discussion. We are obviously very keen to try with the patient's own eggs, as long as it is an informed decision from the patients. Then I'm going to tell another story. Patient number 2, let's call her Ellen. She was 40 years old, single, with a BMI of 25. She was a carrier of a genetic disease that was autosomal dominant. So there was a 50% risk of transmitting that disease to her kids. So so we had to do what we call a PGTM. Okay, this is not PGTA because this was a monogenic disease, a disease that's only present in one gene. And so we did a pre-PGT test to the patient and the sperm donor. We sent the DNA to the genetics lab, and we did her a first stimulation, and we only had 5 eggs. We frozen them. Then we increased the dosage, and we don't know exactly why, but this patient, we changed the medication, and she reacted a lot better. And in the second stimulation, we had 29 eggs, which was amazing. Okay, and then with all of these 34 eggs, we got 20. We fertilized all of the 34 eggs. We got 22 embryos, from which we ended up with 13 blastocysts. Blastocysts are day 5 or day 6 embryos. We did the PGTM to screen for her genetic mutation, and we found out that 7 of these embryos were not carriers of the mutation. And so we tested those 7 embryos. And from these 7 blastocysts that were not carriers of the mutation, 6 of them were found to be euploid, which means they had a normal genetic constitution. So we transferred 1 embryo, and we had the birth of a healthy child, and we still have 5 very good prognosis euploid blastocysts. So this was a really good case. Then we had another case. This one was a very it's an interesting case because her, let's call her Christina. Christina was 25 years old when she came to the clinic. She was married, and she already had a child with a very severe hematological disease. According to the pediatricians that were treating her child, the only solution to treat the existing child would be through a bone marrow donation from a compatible donor, and they spent a lot of time, 3 years, looking for a compatible donor. And so in order to save the life of their child, the only solution would be to have another baby that was genetically compatible with the one that was born. So the theoretical probability of finding a compatible donor was 20%. We had to ask for a special permission to the Portuguese IVF authority, the CNPMA, that authorized the treatment with in order for us to do an HLA compatibility selection. And then we started the treatment. In the first ovarian stimulation, we got 23 eggs. All of them were frozen. We did a second ovarian stimulation, and we had another 33 eggs. We fertilized all of the 56 fresh and frozen eggs, and we ended up with 14 blastocysts. These are theoretically good prognosis embryos. We did the HLA compatibility test, and we ended up with 3 compatible blastocysts, and then we did PGTA to see if they were chromosomally normal. And all the 3 of them were all euploid, were all normal, which was amazing, which is also normal for a 25-year-old. So we did an embryo transfer, and still the result was negative. And then we did we checked the window of implantation for this patient. There was a slight displacement, a 25-hour replacement of the window of implantation. And then we did the frozen embryo transfer at 145 hours, and we had the birth of an healthy HLA compatible child, which was an amazing result. And in the meantime, the transplant was already done, and everything is fine with the already existing child. And this is a very beautiful story. The last story I'm going to tell you is about patient number 4. We call her Carla. She was 42 years old when she came to the clinic, single, never tried to get pregnant as well. also a very good AMH, 3.2 nanograms per milliliter. No PCOS, because sometimes this is associated with PCOS. But then we did an excellent ovarian stimulation. We got 15 mature eggs, great results in the lab, 14 fertilized eggs, 10 blastocysts at day 5, all amazing for a 42-year-old. But then we did PGTA, and all embryos were aneuploid, so none of them was transferable. So this patient was referred to egg donation. This is a relatively recent case. And this is actually the living example of the title of this presentation, because sometimes PGTA can be seen as an extra cost for the patients. In the case of Carla here, you can see that by doing PGTA, we saved her the transfer of 10 embryos. If we were to transfer one by one, it would be 10 negative results after embryo transfer, which is obviously extremely difficult from an emotional standpoint for this patient. So in this case, PGTA saved a lot of time and money to the patient. She had to make a very difficult decision, and obviously what we told her is this: I mean, this can't go better. Okay, we had 15 eggs at the age of 42. We had 10 blastocysts. It's a shame that none of them was normal, but we really can't do anything. We can repeat the cycle, but the prognosis is not good. Okay, and so this is why Carla decided to go with a double donation treatment, and she will be doing it shortly. But it's one of those situations, not only happy stories, obviously, but so PGT helps us to think, helps patients to make decisions, and so this is why we are completely in favor of using it in our daily routine. And this is all I had to share with you. Thank you for listening to me. Sorry for the technical problem, and so back to you, Caroline.
Brilliant. Thank you so much. We can hear you loud and clear, so don't worry. Now it's all okay. It happens, of course. But thank you so much for sharing those, especially those success stories. This is always interesting, I think. So thank you for bringing this up. And as you can see, there are some questions ready. And remember, if you have more questions, go ahead, type those in right now. And now let's go to the first question that we have. So will a PGTA always be done automatically over 40, or is it a recommendation the woman can decide or need to ask for it?
The woman can obviously decide. Okay, this is everything is optional, and patients need to make informed decisions. It is a very strong recommendation. The patient won't need to ask for it because we will recommend it ourselves spontaneously, but it is always the patient's decision.
I think that is clear enough for everyone now. So let me have a look. Next question. So do you always have to have male and female karyotyping results before doing IVF with PGTA?
It's not indispensable. In the past, it was. It's considered to be a good practice. Okay, so a lot of clinics are requesting that, and it's not wrong. Okay, we agree with that. But from a technical standpoint, it is not indispensable. In the past, we were asking this to all of our patients. Nowadays, we're not asking it anymore because from a technical standpoint, it is not indispensable, and some patients, especially in some countries, they have a lot of difficulties to do stereotypes, and so we're not asking for it routinely. But if we could, we would ask. In an ideal world, yes, but because patients don't have easy access to these tests, we can also do the test without the karyotype. Many times we end up not requesting it.
Okay, thank you for the clarification to this. Kat has another question here. So, is there any evidence that aneuploid embryos may correct themselves once transferred? I understand there is some evidence from the US.
I wouldn't call it correct themselves, but there are pregnancies obtained after the transfer of aneuploid embryos. What does it mean? It means that obviously when we do a PGTA, we are I probably should have included a slide on that, but what we are doing is we are making a hole in the embryo and we are aspirating some cells. And so we take usually 5 or 6 cells from the embryo and then we analyze those cells. Obviously, we take cells from a part of the embryo that is called trophoectoderm. Okay, this is a part of the embryo that is usually very representative of the genetic um, content of the embryo, but obviously it is possible that embryos have more than one cell line and that the normal cell line overlaps the abnormal one. That happens in a few cases. I mean, if we look at all the information that we have, the video time lapse imaging, the result, if it's a good biopsy from the trophoectoderm, it is unlikely to happen, but we cannot exclude it. Okay, obviously, in these cases from the United States, patients were informed that they were also having the risk of transferring an embryo carrying a genetic disease because that's what they were doing, and so it was also a risk.
Of course.
So they had to be prepared to do a medical termination of the pregnancy or having some problems with their children. So it was done in an informed way with patients that had nothing to lose, but it's very questionable. Okay, it's not.
Mm-hmm.
There is no consensus in the scientific community on this.
Okay, thank you so much. And actually, I will go to the next question, which is, quite similar as well here. There are a lot of reports in FB groups, Facebook groups of healthy live births from embryos that were tested unemployed or even chaotic. How is that possible? Can embryos really sometimes self-correct, or it could be a testing error? You already mentioned that, but if you
Yeah,
can.
it's. I will elaborate a little more. So it's not about self-correction. It's more about the normal cell lines excluding the abnormal ones. What I can say is this: if the PGTA test is done in a correct way, so about the testing error, obviously happen can happen, and with that we cannot control if they label patient A as patient B, so errors can occur. Uh, I mean, they are very unlikely, okay, but when we're talking about testing errors, then a testing error is a testing error, and so there's nothing. Uh, so it's unlikely to happen, and to be honest, I really don't think those are testing errors. So what happens normally is this: two cell lines, one viable, one not viable, and the biopsy for some reason picked up the cells from that were not viable. Uh, and that can happen. An embryo, when it's called chaotic, it's because it has a high number of aneuploidies, typically more than 4, so more than 4 genetical abnormalities at the same time. So um, when we self-correction is just excluding the wrong cells. So yes, it can happen. No, it doesn't. It is not something that happens every day, and it's not something that we should rely on. Okay, it's I can't give you a percentage of pregnancy while transferring a neuploid embryo, but I can for sure say that it is extremely low. You've seen the results
Mhm.
from iGenomics, the difference, the
Yeah.
gap of pregnancy rate when we're transferring normal embryos, and the population that was not tested is already huge. If it was a population that was transferring abnormal embryos, the problem with this is that this is so questionable from even an ethical standpoint that there are not many studies, or the few studies that exist that have big numbers, because we cannot pick get to 100 patients or 200 patients and say we're just going to transfer you abnormal embryos. Okay,
Yes.
it's just not something that we can do.
That makes perfect sense. Thank you so much for clarification again to this. I will go now to this question. So, am I right in thinking that PGT tests the cells that will make the placenta, not the actual fetus? So, can these results be as reliable in that case? I read many cases where women transfer PGTA tested euploid blastocysts, but there was no implantation.
Okay, it's a complex question. Um, so, um, PGTA tests for the cells that will make the actual fetus. Okay, so the results are reliable. Okay, it's not the problems of PGTA. Let's call it the fragility of PGTA is not related to that factor, okay? Because the correlation between the trophoectoderm cells and the genetic content of the embryo is very well established, okay? There are no doubts on that. However, it is sometimes there is mosaicism, and there are even theories that say that mosaicism is a very natural thing, and so and especially obviously in the placenta that can happen a lot. There are parts of the placenta that have more mosaicism than others, and so this is why sometimes there is some confusion around this topic. So to make it practical and maybe more focused, the relationship between the trophoectoderm cells and the genetic content of the actual embryo is very well established, and there is really not much of a debate on that. And so we can rely on this. This is evidence-based science. However, there are other factors that can affect implantation. In all tests, in all studies, there are no studies where we can get to 100% of implantation. When we get all studies involving PGTA tested embryos have 70 to sometimes 80% of pregnancy. So in 20 to 30% of those cases, we don't have a pregnancy. Why is that? There are other factors in the embryo, like the energy of the embryo to divide and implant and so on. There are other factors in the womb, vascularization, immune reaction against the embryo, other factors involving the mother and the endometrium that can also affect the chances of implantation. Okay, so with PGTA, we are maximizing the odds of a pregnancy by placing an embryo with a normal genetic constitution, if we have that. Obviously, within in the dynamics of the implantation process, there are a lot of other factors that can affect it. And yes, it can be the case that after transferring an embryo, tested embryo, we don't get a pregnancy. Like I said, it's 70 to 80%, so 30 to 20%, 20 to 30% of implantation failure.
Brilliant. Thank you so much for for explaining again this and explaining this question. And short one now here: can Down syndrome be detected with PGTA?
Yes. Yeah,
Yeah.
that's one of the most common findings. Obviously, it is very associated with PGTA,
Brilliant. Thank you. Thanks
with
for confirming.
advanced female age.
Of course. Thank you. And actually, we will now go to this. So, what is the level of AMH needed, minimum, to be able to start thinking about IVF at the age of 41, 42?
Okay, the level of AMH needed minimum Okay, this question is kind of in reverse. So, what we do is this: when we have a 41, 42-year-old patient trying to get pregnant, we assess the ovarian reserve. The ovarian reserve is kind of a puzzle with three parts: the AMH, the FSH, and the antral follicle count. Typically, I mean, at the age of 41, 42, we would give, if it's a patient that says, well, I've never tried to get pregnant, I'm here with my husband or my boyfriend, and we want to have a baby, we would check her ovarian reserve. If everything is okay, having in consideration her age, we would say, okay, let's try for a few months, maybe 3 months or so, um, maybe 6 months, but then we would need to step in. At this age, artificial insemination has a very low probability of pregnancy. We're talking about 2, 3, 4, 5% maximum. Okay, that's what statistics tell us. So in principle, there is an indication for IVF, and obviously, because of the generic risk, there is an indication for PGTA. And so, if that's the case, we can only do PGTA by doing IVF. The recommendation would be to do IVF. So we would probably skip artificial insemination and we would recommend IVF because of the need to do PGTA for the advanced female age question. So what's the level of AMH associated with that? I would say an AMH below 0.5 nanograms per milliliter is a red flag. So if it's below 0.5, I would say go directly to IVF. If it's between 0.5 and 1, it's something for the doctor to assess. Probably IVF as well, between 0.5 and 1. Above 1, we could consider waiting for 3 or 6 months, but then IVF with PGTA if we don't have a pregnancy before that.
Okay. Thank you for the clarification. I do believe it helped. And now we will go possibly to our final question. However, if you have more questions, you know what to do. Go ahead, type those in. And the question is, what is your opinion about cytoplasmic transfer?
Well, I'm very much in favor of it. Okay. However, it is an experimental procedure. Okay. So what we need to have in mind, to bear in consideration that this is something that I see as extremely promising science. There have been some studies in Greece. Actually, one of the main studies was done by a Portuguese scientist based in Barcelona that was working on this project in Greece. So we live in a global world. His name is Nuno Barge, and so they've achieved amazing results with very poor prognosis patients. Okay, so what I can say is that it can be the future. There is a very high chance for this to be the future, but it is not yet the future. Okay, it's something that looks extremely promising. A lot of people are working on this. We still need a lot of research to say that this will be the solution, but this is something that I mean, if I have to guess, I would say this is one of the most promising techniques that will, maybe in 5 years, I don't know, maybe 10 years. I really, obviously, this is predicting the future, but I think in a few years this will be a reality in routine clinical practice. Not now. Okay, it's still an experimental procedure.
Okay, thank you for sharing your opinion on this, of course. So thank you for that. One more question in the meantime we did receive. So, but the egg has to be euploid for this to work, right? This is a follow-up, yeah, from the previous patient regarding the...
More or less. Because so what is this? So in when they do cytoplasm transfer, they remove the nucleus from the egg of of a patient, and then they transfer it to, and, and then they get an egg from an egg donor. They remove the nucleus from the egg donor, and they replace the nucleus from the patient inside the egg from the egg donor. So in the cytoplasm, there are the mitochondria. The mitochondria are responsible um, for providing the energy for the cell to divide and so on. And they, through a mechanism that is not really well known, there is some kind of capacity to repair potential problems with in the DNA of the nucleus. We believe that this new cytoplasm, a healthy cytoplasm from a younger person, can help the embryo to correct the genetic mistakes at his nucleus. And so this is why it is a really promising technique. And so the egg has to be euploid, not necessarily if that capacity to correct the nucleus error really exists. This is something that's still under research. We don't know the mechanism, but we believe that there could be some type of of, um, of capacity. This is a self-correction, not the case of the embryos. Okay.
Mm. Okay, brilliant. Thank you so much. Someone is typing, so let's give it a second and see. Yeah, it's a thank you. So I believe we will be finishing for today. But thank you so much, everyone, for joining, for your questions. We talked about PGTA, but we also talked about cytoplasmic transfer.
Mhm.
Why not? So I'm glad that we were able to explore those topics as well. Dr. Silva, as always, thank you so much for joining. I do believe it was very useful to all of you. Thank you for your questions. And
Thank you.
before we finish, I would like to also ask again if you wish to share any of the topics that you would like us to discuss next year. We are preparing, of course, the topics for next year. We are starting to do that, so we want to definitely ask your opinion. If there are some topics that are missing, please type this in. You can do it in the chat as well, and of course we'll be happy to receive it. You can also send me an email, and I'll be happy to have a look at those. We are gathering all of those topics, so feel free to share your topics. And be in the meantime, Dr. Silva, anything else you wish to discuss before we finish for today?
No, I'm okay. Well, I just wanted to wish everyone good luck for their treatments. I know IVF is really challenging and it's difficult. I think that PGTA is really something that you should consider. Obviously, if you are within those age groups that I mentioned, and I hope I have helped people that were listening to this webinar so late on a weekly day. Okay, so good luck to
No
everyone,
doubt.
and thank you so much, Caroline, for having me here.
Thank you. It's always a pleasure. If you missed any of the webinars with Dr. Silva, you can go to our website. He will be all the webinars are available there. But also, I just want to add that Dr. Silva will be back with us, not in English webinar for now, but on Monday he will talk about. I don't remember exactly if egg freezing, is that correct? I think egg freezing,
Uh, to be
is that
honest,
right?
I need to check.
It's okay.
It's
I just
I have it here. I can say it's a French webinar.
definitely
It's called IVF and fertility treatment for women
true.
over 40s. What are your chances?
Definitely.
Okay, so I will be speaking for the French public on Monday.
Yes, and there is also one webinar more in German, so Dr. Silva can speak many languages, and he's ready to share this his experience with you in different languages as well. So stay tuned. There are more events coming up, and in English as well. So don't worry. So thank you everyone for joining. As always, it's been great to have you, and of course we will be back on Wednesday. We will talk about male factor. So if this is something you wish to learn more about, or you have some questions, join us. We will be there with Dr. Angela Ianetsa from Clinica Tamres. So I hope you will be able to join us on Wednesday. That's it for today. Thank you for joining. See you soon. Dr. Silva, as
Thank
always, a
you.
pleasure. Take
Bye
care.
bye.
Good
Bye.
night.